Good afternoon, everybody. My name is Melanie Escher, and I'm with the Arizona Telemedicine Program, the Southwest Telehealth Resource Center. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So again, welcome to our webinar today. Some tips and notes: when you join the webinar, your phone or your computer microphone were muted. Please use the chat function for any questions. We'll have some time at the end for Q&A. And we have a post-webinar evaluation that will pop up behind your screen. I will also put it in the chat and you can connect on it. And I'm sorry, I did not update this slide. There is not CME credit on this presentation. There is no CME credit on this presentation. Disclaimer, opinions expressed in the presentation and on the following slides are solely those of the presenter, not necessarily those of the organization sponsoring the webinar, and the organization does not guarantee the accuracy and reliability of the information provided. There's my public service announcement. And double check our website, come back to our website and check for more upcoming webinars and sessions that will be coming soon. And again, your opinion is valuable to us. And again, sorry, there's no CME credit on this one. I was reusing a slide deck that I got caught all of those. However, I'm going to introduce Tara Scalar. She is our Faculty Director of Health Law at Arizona Law and the Associate Director of Telehealth Law and Policy with the Arizona Telemedicine Program. This is the state telehealth policy landscape, the 2024 developments, and Tara's going to go ahead and introduce our presenter. Tara?
Sure. Welcome, everyone. It's great to thank you so much for joining us. I will also be moderating our webinar today. So any questions you might have, please put in the chat and we'll hope to get to them within the last 10-15 minutes of the webinar. I am thrilled that Quinn Shane could be with us today. Quinn is originally from Phoenix, so this was near and dear to her heart to present to our Arizona Telemedicine Program and our Southwest Telehealth Resource Center. She is a nationally recognized healthcare strategist and regulatory advisor, works with clients at the intersection of law, policy, and politics. She currently serves as the strategic policy advisor to the American Telemedicine Association, which we often call our ATA, a number of healthcare entities, and Tusk Venture Partners. She also served as the vice chair of the Uniform Telehealth Act, which is a real critical piece of legislation in the area. So I will now turn it over to Quinn, but we are in for such a treat of a real broad landscape of what's happening right now in telehealth across the country and her insights on what we may see going forward. So Quinn, warmest welcome. Thank you so much for joining us.
Thank you, Tara, and it's great to be here. As Tara mentioned, I have spent my formative years in Phoenix and in Scottsdale, where many of my dear friends and family still live, so it's great to be with you. So I am currently based in Chicago now, which may make you question or believe or trust anything that I'm about to say. So just a little bit about me, as Tara mentioned, I've worked in politics, law, and policy my entire career. I started out in politics, then worked as a litigator in healthcare. But for the last almost 10 years, I've been really working at the intersection of policy and politics and technology. My focus has almost exclusively been at the state level. I do a little work at federal, and I'm most interested in how policy can advance or when does it hinder the adoption of virtual care solutions. And in working on that question, I've advised, small startup healthcare entities when they're almost just at an idea stage, to large health systems, to investors, to patient groups, and as Tara mentioned, the American Telemedicine Association. But today I'm here to share with you my own opinions, what I'm finding noteworthy, and shouldn't be associated with anyone that I work or advise. So just to give a little bit of agenda of what I'd like to walk through, I'm going to start with kind of a telehealth policy 101, just so we understand and I think level set, because it's often really confusing as to where states regulate or where they have the authority and what the legislation can actually touch on. We're going to move to some policy and legislation addressing telehealth practice standards. Then we're going to talk about one of my favorite topics, interstate licensure developments. We're going to look at some telehealth payment legislation, and then I want to spend some time on some emerging policy issues that, while they're not telehealth specific, I think do have significant implications on the delivery of virtual care. So just to level set a bit, I will mention some things happening on the federal level, but we're here to talk about the very exciting world of state legislation and regulation. If you've ever heard me talk before, which I don't know that you have, I often say don't sleep on the states. That's where things happen. I believe the federal government's been talking about telehealth policy for the last 3.5 years and keep kicking the can down the road. That's fine. But in the meantime, states have passed hundreds. Every state has passed some law that has to do with either the practice or the payment of telehealth. So when we're thinking, when somebody comes to me and says, this issue is a real barrier, or this issue is really helping us to grow, how do we find policies to support that? The question kind of is, does this have to do with the practice of telehealth or the payment of telehealth, or maybe both? And what I mean with the practice of telehealth, those are the types of laws or policies or regulations that affect everybody, whether or not they're taking public payment, private payment, cash pay. This is what rules and policies are if I just want to deliver care. And that type of policy is regulated primarily, sorry, I'm losing my voice, at the state level. And that's through state statutes, such as the Medical Practice Act, the pharmacy codes or occupation codes. It can be in administrative rules. It could be in the regulatory bodies overseeing the various professions. And that is an area kind of state jurisdiction or state authority. There are some rules, obviously, and laws and regulations at the federal level, but it's more narrow, and that has to do with prescribing of controlled substances. There are some rules around privacy, cyber data protections, data sharing, and then the FDA and the FTC can touch on, the practice of healthcare, the practice of telehealth. The payment of telehealth is regulated at both federal and state, extensively at both. Obviously, we have all of our payment policies at Medicare, Medicaid, and through CMS. There's also some rules there around self-referral kickback, but it's also regulated extensively at the state level. So commercial payer statutes, which we'll talk about, that mandate coverage parity for telehealth, that's going to be a state issue. Certain Medicaid policy or statutes that might mandate coverage of certain telehealth modalities, that's going to be a state issue. This can also be found in state rules and policies. So it's a lot of information. This isn't intended to capture everything that's out there, and it shouldn't be seen as fully comprehensive, but at a high level, it just helps us understand where state legislation is going, and what's in their authority. One example, before I move, is like during the pandemic, the White House came out with a press release or an executive order, and it said, the White House relaxes licensing rules. And a bunch of my friends and clients sent it to me saying, okay, here we go. We can practice across state lines. Well, 50 state medical boards were quick to point out that that really wasn't the White House's jurisdiction as to determine whether providers could cross state lines. That was up to the individual states. So just keeping that in mind as we talk through today. And just going one more level, telehealth policy can often, the way I think about it is answering one of these questions. When we see a bill at the state level or regulation, it's often addressing, who can deliver healthcare services using telehealth, or what rules must they be following in delivering the telehealth services, what technologies must they use, what steps must they take. It might be addressing where the patient or the provider needs to be during the telehealth encounter. Or finally, it might be addressing when payers, whether public or private, must reimburse for telehealth. So looking at 2024 and what we've seen so far, there's nearly 300 bills out there that I think are substantively touching on issues related to telehealth in 40 states right now. Now I've been tracking this for at least 8 years. And every day I look at different bills that get filed. I would say on par, we're about at the same, maybe a little bit less than we have been in post PHE sessions. The PHE happened and about 4 years ago, and at that time, a lot of states started to look at their codes or their regulations and realized they were outdated or silent or inconsistent. And in that 2021 session, kind of the session immediately following, we saw, I would say 800 different pieces of telehealth legislation. And we had at least, 5 governors mention telehealth in their state address. And we saw really broad, far-reaching bills that touched on a ton of issues. I call those often omnibus bills. Arizona had a pretty landmark one in 2021, 2454, I think, that touched on a lot of different elements of telehealth. We've seen less of that right now. What we're starting to see is more of a narrowing and a targeted refinement, and less of these really broad, sweeping telehealth legislation that covers payment and practice and licensure, and more of like targeted fixes that could be as narrow as something of, you need to cover remote fetal monitoring in a state Medicaid plan. It might be as specific as that. So the question is it good or is it bad? I think it's largely good that we are moving towards telehealth being seen as healthcare, and less as, a separate type of service, which is, in my opinion, not. It's a way to deliver care. And, I think the number of bills we have in this space will continue to go down as it more and more is seen as a care delivery that needs to follow the standard of care. So going into kind of the first category, legislation affecting telehealth practice standards. By this I mean, and we have a lot of different maps here, kind of covering that who and the what. So who's able to deliver care via telehealth, and what rules and standards must they follow? So we saw a number of states taking this on with legislation here. And this is everything from prescribing requirements, what I'm calling non-physician providers, so the use of telehealth consistent with scope of practice, outside of not just physicians, but the variety of members of a care team. We also have a color here for kind of practice standard changes. So that might be steps that different providers have to follow when using telehealth services. So states are updating or thinking through, what do referral or continuity of care requirements or record keeping requirements? Again, these are more things a little bit at the margins versus, broad telehealth legislation. So going through a few noteworthy bills in this category, I want to start with Washington State. Tara mentioned early in the introduction that I served as vice chair of the Uniform Telehealth Act. I think this group might have heard from Kristen Madison, who was the reporter from that act. The Uniform Telehealth Act was part of the Uniform Law Commission. It was a over 3-year process that convened a variety of stakeholders to come up with what that group considered to be a model or uniform legislation that all states could introduce to better enable interstate care via telehealth, with the idea that if the practice standards were uniform across the state, it would, better allow multi-state practice. The Uniform Telehealth Act had kind of 2 components. One had to do with uniform practice standards, and the others had to do with authorization of out-of-state providers to come up with a uniform framework there. I will say, I don't know if this was mentioned, a lot of the Uniform Telehealth Act actually drew from what Arizona passed in 2021. It was one of the kind of guiding models that helped define that act. So Washington State has recently enacted, I would say, a large majority of the Uniform Telehealth Act this session. I think it's supposed to be signed today. It's also currently pending in Washington, D.C. and Rhode Island. And the Washington bill defines telehealth broadly as the use of synchronous and asynchronous technologies, makes clear that a practitioner-patient relationship can be established through telehealth through both synchronous or asynchronous technologies when consistent with the standard of care. And it also permits, all practitioners kind of licensed under the state's occupation code to deliver services via telehealth if it's consistent with their scope of practice. And so what that means, it doesn't necessarily name out, only these three professions can use telehealth. It contemplates telehealth as, one way to deliver care that providers may use. Previously, Washington State didn't have a statutory framework. They had an insurance framework, regulating the payment of telehealth. So this is a step forward for the state. A few other examples: South Carolina enacted some new legislation last week. Again, it broadens the practitioners eligible to deliver telehealth services. It removed some outdated terms. They had a reference to lifestyle drugs, which was never defined, but prohibited telehealth to prescribe those, as well as prescribing by questionnaires. That's a word that, many providers and practitioners can get tripped up on in statutes. It's the legacy term that was enacted kind of during the pill mill internet prescribing days, where people would fill out a form and not form a patient relationship. And so some state frameworks still include it, and sometimes can cause confusion between an asynchronous kind of adaptive intake that's then sent to the provider, and then the provider responds back to the patient. So we continue to see some states struggle with the questionnaire language. South Carolina removed that. Florida had an interesting bill on teledentistry patients. It sets up a new framework there, requiring them to have a dentist of record, as well as to have an in-person exam, or at least have records from that in-person exam. I would say some people in the teledentistry space felt like it was a little restrictive because of the in-person mandates. Georgia, I believe, is contemplating similar legislation. Connecticut, this is just an example I included. A lot of states post-pandemic put in kind of a 2-year temporary framework, following Congress's lead to kick the can, as I like to say. And most of those have expired and they've adopted something permanent. Some still have it in place. Connecticut is one of those. Both their payment and their practice flexibilities are supposed to expire in June, and there's legislation to extend them further. And lastly, Missouri, it listed 2 bills there. This is just another issue that we've continued to see, which is around the definition of telemedicine. From a practice standpoint, does it include audio only? Does it not? Is audio only treated separately? I would say pre-pandemic, audio only was often seen as not part of telehealth. Didn't mean it couldn't be done and used by providers. It just wasn't typically seen in telehealth statutes across the board. Now it is more commonplace. Missouri is seeking to add that. There's also an interesting bill there around geographic proximity requirements. And this is getting to the who can use telehealth. Some states have made clear that nurses or nurse practitioners can use telehealth consistent with scope of practice. But in states where they don't have independent practice or require supervision, there's often been questions of well, what does supervision mean in the telehealth context? Missouri has a 75-mile rule for nurse practitioners, long dated, that the nurse practitioner needs to be within 75 or 50 miles, I believe, of their supervising practitioner. Well, in the telehealth context, that doesn't make a ton of sense if they're 1 mile or 100 miles, because they're going to be doing the care remotely. So there's legislation there to clarify legislation from last session that would remove that requirement in the telehealth context. So I think as a general matter, what we're, seeing through all of this is, and which I think is positive, is growing acceptance of care delivery through telehealth modalities, authorization of new modalities, and recognition that, additional health professions can use telehealth or virtual care consistent with scope of practice and standard of care when it would make sense for the patient and their condition. So another key part of, I would say, the practice standards is the area of remote prescribing of controlled substances. The states that do have telehealth practice acts, often outline how treatment may be prescribed, both controlled substances and non-controlled substances. Some are silent, which people interpret to mean can be done consistent with the standard of care and the other laws on the books. Some are explicit. I think there was a presentation that you guys had on this recently that outlined this quite well. So remote prescribing controlled substances are something, going back to the chart, that's regulated both at the federal level and at the state level. So at the federal level, as many of you know, the DEA does regulate the prescribing of controlled substances. And there is a congressional statute on the books, the Ryan-Haidt Act, that generally requires providers to see a patient in person prior to the prescribing of any controlled substances, unless one of these very limited statutory exemptions is met. During the COVID-19 pandemic, recognizing the need to continue care, providers were temporarily permitted to prescribe certain controlled substances without an in-person visit through the end of the PHE. The DEA, along with HHS, was supposed to come up with a new framework to address post-PHE. Last February, they published 2 proposed rules, which in essence would have gone pretty similar back to the pre-COVID policy. It would have, I believe, prohibited Schedule 2, and it would have only allowed other schedules for 30 days. There was tremendous pushback, over 30,000 comments. Listening sessions, the DEA kind of scrapped the initial proposals, and then in October issued another extension, which lasts until December 31st, 2024, and said they are coming out with, taking another crack at the rules. And then those are in the process of being developed. I had heard they were going to be released in February, but here we are in March. They said the kind of final rules for people to start to implement would be ready by this fall. We need to get moving if that's going to happen, but I think there's a chance it might be extended further. In any event, that's the federal level, and that serves as a floor. Practitioners must also comply with the laws in the state in which the patients are located, and some states are going to be silent, some are going to defer to federal standards, and others have rules that largely prohibit the prescribing of controlled substances via telemedicine if there has not been an in-person exam. Alabama has something to that effect. Some states only prohibit certain substances, some only say Schedule 2. So, kind of post PHE, or we've started to see a few states either reconsider what policies they have on the books, and others have signaled that they're waiting a little bit for the DEA to act. Last session, Florida revised theirs to allow certain Schedule 2. They had previously banned it. This session, we have Hawaii has 2 pending bills to address the requirement that prescribers be physically located in the state at the time of prescribing. There's regulation on the books that suggests while you can remote prescribe, the prescriber has to physically be in Hawaii, which has caused some difficulty in those instances where the prescriber obviously is not in the state, even if they are licensed. One of those bills would make an exemption for gender-affirming care. Another one of the bills would make an exemption for when the patient is on a hospital facility, but the provider, is located somewhere else. I'll just go back to it. South Carolina, which recently enacted legislation, actually addressed controlled substance prescribing as well. They removed changes to allow prescribing for medication-assisted treatment of opioid use disorder. buprenorphine is a controlled substance, and the Medical University of South Carolina was very active in that bill because they were not able to treat certain patients because South Carolina had a ban on telemedicine prescribing for controlled substances. I also want to just note Georgia's medical board. I excerpt something from the AGC. In December, they announced they were reverting to their pre-pandemic policy, effective in 3 weeks, January 1st. There was a sudden outcry. The hospital systems in the state, made clear that it would be very difficult for them to provide adequate care if the flexibilities were rescinded so quickly. So the board restored the flexibility consistent with the DEA, but said it's reverting to its pre-pandemic rules effective May 1st. It's still supposed to come out with additional guidance there, but we have not yet seen it. Okay, I'm going to move on to one of my favorite topics, licensure flexibilities. So as many of us know, during the PHE, when there was an increased demand for virtual care, states implemented a number of measures to make it easier for providers to deliver care across state lines. Every state, I believe, to my knowledge, implemented something to ease the burdens of licensure. Typically, those required that the provider at a minimum be licensed in good standing in some states. At this point, every state has taken away those temporary policies. But in the meantime, the legislature, as I said, the pandemic kind of woke us up to look at the laws on the books, the regulations on the books, and think, do these make sense? Many legislators and policymakers said now's the time to reform some of our regulations around cross-state prescribing if we're really going to use telehealth to its full potential. And a number of different models have been proposed. This map here shows in blue kind of states that are continuing to pursue different types of licensure flexibilities through legislation. In red, I highlighted states that have implemented what I'll call a registration model and discuss in a second. But I think the larger takeaway here is that there continues to be, we're in our 4th session since the pandemic. And I would say of all the areas, if we include the compacts, which are not reflected here, it's probably the issue that remains a little bit top of mind in the telehealth context is, how are we addressing workforce shortages, continuity of care in a way that we're actually, in my opinion, leveraging telehealth to its full potential. If we're only using telehealth in the context of patients within a geographic proximity, that's wonderful and it's great, and it helps address those issues of convenience and time and travel. But if we really want to ensure that patients can access care when and where they need it, I do think we need to think, how do we leverage providers in good standing who are available to provide quality care and make sure that it's not burdens of licensure that are holding it up. On the flip side, we have to think about, states maintaining accountability over patients treated within their borders and ensure that patients are protected. So it's been that kind of give and take a little bit that's dominated these policy discussions, and I think has been a part of how states are thinking through what licensure flexibilities can mean. So they've kind of taken, I would say, 3 different pathways towards addressing this. In Washington State, this is kind of one example, and these are, what I often call them common sense exceptions to licensure. And this is actually part of the Uniform Telehealth Act. They adapted them slightly, but these are the scenarios in which a state says you do not need a license in order to treat patients here via telehealth. A number of states have these, and they usually will fall in the realm of a continuity of care situation for typically limited to the same condition. So if you receive surgery out of state and you come home and you want to, stay in touch with your provider, that provider doesn't necessarily need to be licensed in your state. The other one is, where patients are visiting or traveling or temporarily in the state so that they can continue their relationship with their provider in their state of residence. And then also in areas around specialty assessments or diagnosis or consulting with the patient's, provider at home. So those are areas where there's an exception to licensure. Beyond that, some states, often following Arizona's lead here, have considered an alternative way of being authorized to deliver care. So we have exceptions, we have licensure. Is there another pathway that the state is saying you're authorized to deliver care here if you're delivering care via telemedicine? The Uniform Telehealth Act added that, and Colorado, as well as Wisconsin, also had a bill pending on this. It passed one house, but then Wisconsin just convened, which these are what I call the registration model. It allows a provider in good standing to provide healthcare services in a state if they register with the applicable board and meet a number of requirements. The states differ on the requirements. Usually there's a consent to jurisdiction. There might be a fee. There might be a need to have a registered agent. They kind of differ on some of the requirements to take advantage of the registration, but that's a framework. I'm just going to go back here that's been growing in a number of states. These are the states in red. Some states, Idaho and South Carolina, have limited this to behavioral health only. Delaware takes an interesting model. They allow registration, but only if you're in a profession for which there's not a compact, or you're in a state of which does not participate in compacts. Some allow the registration to be temporary. So, they, as I said, they'll differ a little bit, but on the whole, they're representing an idea of a streamlined authorization to deliver care in the state, recognizing that the incentives for a telehealth provider are going to be different than somebody who is delivering care in person. And those incentives, if the fees and burdens of licensure are required, they might not choose to deliver care in that way. I mentioned the compacts. We've continued to see tremendous growth here. Generally speaking, a compact is kind of a formal legal relationship among the states where they decide on uniform standards for the practice. So what's going to be required to be a part of the compact, a certain number of schooling, accreditation. So in some services and some professions, it might not be that every, this is going on in the counseling compact in California, for example. Certain counselors in California will not be eligible if, in the unlikely event, in my opinion, that California would adopt the counseling compact. Some counselors in California, because of the requirements to participate, would not be eligible. So the standards are uniform across every state that adopts it, and it allows an easier way for multi-state practice. I will say some are easier than others to leverage, but they continue to grow. The Social Workers Compact, I believe, was just introduced this past year. Already has 4 states, pending in 20 states. The Counseling Compact and Site Pact have grown tremendously. So this continues to be another, I would say, area that I don't see slowing down at any time. So that's exciting. Okay. I also want to just address legislation affecting payment of telehealth. We could do a whole webinar on this. As I mentioned before, federal and state have kind of jurisdiction over how telehealth gets paid for. I have some general statistics there pulled from Center of Connected Health Policy, the authority on all things telehealth. So what I would say is we're seeing a little bit less here than we have in the past in terms of public and payer. Part of that is because, over, trying to think how many, okay, I have my notes here. Yeah, so coverage, if we look at something like coverage parity, that's payers have to cover a service if it's covered in person, and that would be a private payer, commercial coverage, statute, they'll say, if you're covering a service in person, you can't decline to cover it because it was delivered via telehealth. We already have over 40 states, depending on the legal interpretation, that have this. So it's not surprising we're seeing this slow down a little bit. Pennsylvania, I believe, has a bill this session that they've tried to pass 4 or 5 years. It's a comprehensive telehealth bill that includes something on coverage parity there. The other issues in the commercial market is around payment parity, and that means that it would be reimbursed the same as it would be in person. Around 25 states have that already existing on the books. We're seeing, a number of states continue to consider that. New Jersey, Vermont, New York all have legislation right now pending around that. I would say on the issue of commercial coverage parity, it often can differ. It's not going to be universal, every service, every provider. It's where it is introduced in legislation or enacted, it can be limited to certain modalities such as live video or behavioral health, or if it's going to be audio only, it would probably just be for behavioral health or certain circumstances. We're continuing to watch that and those play out. On the Medicaid, a few interesting bills pending right now. I think in California, there's one around reimbursing for store and forward and asynchronous care. California did a pretty substantial overhaul on their telehealth Medicaid policy a couple of years ago. And one of the key issues was around what modalities could be used to form a relationship for Medicaid beneficiaries. They allowed asynchronous care, but only in very limited circumstances. There's a bill pending right now that would broaden that. I think it has a substantial chance of passing. I should also say Washington State, for both their public, it should actually be red, I will change that. For both their public and private payer, there was legislation that passed this year around use of audio only and coverage requirements for that. The circumstances under which a provider can form a relationship to receive payment. They need to have the patient's record, a health record of the patient. They don't necessarily have to have seen the patient in person. That was a contentious piece of legislation. It had been temporary, and now, provided it gets signed, will be a permanent effect to reimburse for audio only. Okay, one area I did just want to touch on, because this comes up, and I think it is interesting, and one of those unintended consequences is something I've seen. Sometimes, I would say mainly for virtual only or predominantly virtual providers or telehealth, they can run into issues in delivering care to Medicaid beneficiaries. So some states require providers to have an in-state brick and mortar address to be considered an in-state Medicaid provider. Otherwise, the provider, even if they are licensed, let's say I'm going to use California as an example. If I'm living in Arizona and I'm a California licensed provider, I could be required to have an address in California in order to enroll in the Medicaid program. Sometimes it's not just an address. It will say that you need to have the ability to make referrals or do periodic in-person visits, which again is going to limit the ability for an otherwise licensed provider to deliver Medicaid beneficiaries care if they are out of state. So I gave a couple of examples of states that have this. Michigan's one. They recently had a policy here that they cannot be continued infrequently without frequent and periodic in-person evaluations. My understanding is the department's reconsidering that because a number of their behavioral health providers with a shortage, were licensed in Michigan, but they were not in geographic proximity to the patient. North Dakota recently addressed this in updating their own policies to make clear that telehealth providers who are licensed in North Dakota, even if they're out of state, aren't subject to out of state provider rules under the program. So this is something we're continuing to see. A few states, Illinois has something on this. A couple states passed legislation last session to make clear this kind of in-state versus out-of-state enrollment issue. And I think we'll see a little bit more moving forward. In my last 5 minutes, I want to touch on a few emerging issues that could also, as I said, have their own webinar. So the first is around health data privacy. Again, this is an area that has regulation extensively at the state level as well as at the federal level. For those of you that follow federal updates, last December, or a year ago December, the ONCHHS released guidance around third-party website trackers that were often found on just welcome websites for healthcare entities that were collecting and storing data from people that might have just visited their homepages. And ONCHHS, or excuse me, OCR, not ONC, issued some guidance around that, and that applied to HIPAA-covered entities. Shortly thereafter, FTC put out something similar. Well, at the state level, a number of states are changing and updating, this is since 2018, their own frameworks around consumer data privacy, which often has specific provisions that relate to sensitive data or health data that has implications for telehealth entities, healthcare entities, but telehealth entities often, because they have an internet presence, can be caught up in this. There's kind of two different types of bills where this is being affected. So one, as I said, are these omnibus comprehensive privacy bills that have specific rules around the collection, sharing of health data. But in the last year, following Dobbs in particular, we've seen bills that focus specifically on health data with very strict requirements. Now, some of these bills totally exempt entities that are covered by HIPAA, and some only exempt PHI from their requirements. So adding on to our patchwork of state regulation of the practice of telehealth, from the payment of telehealth, we now have additional complexity around state privacy law. States in blue, I think 14, 15 if you count the Washington's health data bill, that have laws on the books around this, and a number of both consumer data bills and health data specific bills being contemplated by various legislatures. So that is definitely something to watch. The second issue, again, I'm not going to be able to give this enough credit that it warrants. States are starting to talk about AI, and some of them are specifically focused on healthcare. More of them are focused, I would say, on broader sector agnostic approaches. What I'm seeing now reminds me a little bit of the health data framework that we saw kind of post CCPA, California's bill in 2018. They're starting to talk about it. There's a lot of work groups being formed and commissions to look at the issues, to think about what a framework should be. There's a lot more cooperation, I would say, among the states in thinking through approaches so that we don't end up in the same place that we're at with privacy. There's also discussions of, waiting to see as President Biden has a very ambitious AI agenda and a number of deadlines, many of them healthcare specific, coming up. So some states are kind of waiting to see what's going to happen there before coming up with their own regulations. But there are some pending. Take a look at the Utah legislature recently passed a bill around private sector AI deployments. There's transparency obligations for private entities deploying AI, and those in regulated professions, which includes healthcare providers. There's this bill in Georgia that's gotten so much press, it never went anywhere, but it was very broad in how it was going to restrict the use of AI in healthcare, prohibiting the use of AI to the sole use of AI in making any type of healthcare decision. And the way it was written was very broad, that caused a lot of concern, I would say, among stakeholders, that it could unnecessarily impede innovation, and that it really needed to be narrowed. I think the sponsor understood that. I definitely watched legislation in California, Assembler Bauer-Khan's bill, Connecticut, Senator Roney's bill, and in Oklahoma, they are more addressing algorithmic bias as a general matter, but it will have implications in the healthcare sector because it affects what they call consequential decisions, and things that have to do with healthcare always are included within that consequential decision. And it will set out requirements, as I said, for impact assessments, transparency, requirements on both the people that develop the AI tools, but also those that deploy them. And lastly, here, Federation of State Medical Boards recently put out a draft report. I believe they're circulated it for feedback, and they're looking at the issue because, as I said, at the beginning here, there's a lot of discussion at the federal level of AI where it should be, but at the end of the day, the regulation of the practice of care is going to fall on the states and the regulatory boards, and they will have the power to say how providers can use these tools in practice. So definitely something to watch there. Lastly, this is an interesting issue that we're seeing, I'd say, last 2 to 3 years, regulation of private investment. There's definitely a lot of activity at the federal level. The FTC recently convened a hearing on private equity investment in healthcare, as well as issuing an RFI that's looking at corporate or private investment in healthcare entities and a number of questions. But states have been doing some work here as well. One of the things that they've been doing are kind of what I'll call transaction approval, where an entity is there's going to be a change of control of a healthcare facility. The AG or another applicable board needs to receive notice of that transaction, its potential impact. And in some states, the AG or other regulator has the ability to review and approve such transactions. So there's actually a pending bill. California already has a framework in place. There's a pending bill right now that would give additional authority to the AG there. Minnesota introduced some legislation that would put a moratorium on private equity or hedge funds from investing, increasing ownership interest in healthcare entities starting August 1st. And Oregon had a very short session, but they almost passed a pretty consequential piece of legislation that would have changed the state's corporate practice of medicine doctrine, and put a number of restrictions around how physician practices often contract with private equity or other investors. It's often called a friendly PC model, and it would have made that very difficult, if not impossible, to continue to use in this state. So with that, I'm happy to stop there and answer any questions. I haven't looked at the chat. If we want to.
Hey, yeah. Hi, Quinn. This has been really phenomenal. Okay, you can go ahead and stop sharing your slides.
Okay.
We have a few questions come in, and I think you mentioned at the start that one of your favorite areas is cross-state licensure. So
Yes.
if you're around that, and I have some of my own, some that you and I have been having back and forth, and then we have one about a Medicaid related question. So let's start with the licensure, because that's really at top of mind, especially given the current case working its way up the New Jersey courts. But it's really just this reaction to and I think what's resonated with this group here is the common sense exceptions. So if you could just elaborate on that a bit more, and I'm also happy to chime in, just what you mean by some of these common sense exceptions, and just generally, like, how many states tend to have these, like as a third, a half, like are there certain regions, just your insights on those exceptions, because I do think that we're seeing those because states are doing that flexibility, these little tweaks and nibbling at this area in certain spots. So I'd love to get your thoughts on it.
Yeah. So I can try to put it in the chat. The FSMB actually put out a document that they routinely update. And again, it's only with respect to physicians, but kind of lists states that have exemptions for continuity of care, specialty consults. What was the other one that I was saying? And follow-up. So I would say, I think it's more than half have something. I would say in terms of like least risk or more recognition, the consult to consult where your individual provider is consulting with, or with your involvement, a provider in another state who is not licensed, often seems to be the most kind of flexibility. The follow-up visit, I would say, probably is around the next, where you've had surgery or a procedure at at the Cleveland Clinic, and now you're back home in Arizona. The traveling patient exception, I'm going to say college student move next. Also, maybe I'd say less than half. The trickiest issue, I think, is the patients that's moved, or the college student that's temporarily away, because it's not, everybody really would like, and it's so much easier to have clear lines as to, well, how long is too long, or what is considered one condition. Is behavioral health considered, one instance that I can then use for 3 years? I wish I could say there's always clear guidance on that. Some states have it. Virginia passed something last year that was very clear. I think you have 1 year.
Yep.
But other states aren't always going to give that type of specificity. So I continue to think that somewhere with advocacy that we hopefully will see states move. The Harvard group led by Dr. Marotta and others put out, and again, it's only for physicians, I wish they went to more provider groups, that kind of said, we all have agreement that it's in the best interest of patients in these circumstances that they continue to see their providers, and it does not make sense that a provider would need to be licensed there. They can still be accountable there. And, in all my work in state policy, I've yet to hear very significant concerns about that. Where they do come up is, well, what if they do it indefinitely in local provider? And, that would kind of be the pushback that I would hear. What has more pushback is just the idea of, similar to Arizona's registration model or any alternative authorization, where patients can form relationships versus continue relationships with patients in a state where they do not have a license. And there's a lot of reasons for that. I think some of it's competitive concerns. And I think some of it has to do with, just a lack of familiarity of what telehealth can do, and what those relationships look like. So I don't know
That's
if that
great.
answers.
Oh my gosh, I love the distinction you made between forming relationships and continuing them.
Yeah.
Because, I think 2 other areas that I thought as you were addressing this with college students and moving, a big issue for Arizona and other warmer states are snowbirds,
Snowbirds, yeah.
and how critical it is for them to have continuity of care going forward. And then the other issue is the mental health deserts we have across the country, and forming relationships versus continuing relationships. So one of these exceptions that Quinn brought up was on the behavioral health side, where it does seem to be a pretty consistent carve out for both allowing more out-of-state licensure access as well as audio only. Anyway, certainly such a critical area to watch. Did you want to add anything else about it?
Yeah, I mean, how many policies?
Yeah, go ahead.
I think that's a question I get often, which is like, well, how often are they enforcing? And, they're not necessarily going to know that you're delivering care without a license. What was hilarious to me when the pandemic hit was that, you know, a lot of people didn't know that when they were treating their patients who were snowbirding in other states without a license, that they were violating the law. I mean, they were technically violating the law. Health systems were more in tune to that and started saying you couldn't do it. So are people going to do it, or are they aware? I haven't seen a lot of lawsuits. It probably comes up in a context of malpractice, but or not malpractice, in a issue where something has happened. But that being said, like, it is the policy in place, and we do really need to think about what makes sense. Again, balancing accountability, balancing incentives to make sure we're getting providers where they need to be. I haven't come across any provider interested in delivering multi-state care who would not consent to jurisdiction of that state's board for treatment of that patient. Or wouldn't say, if they said, well, you have to follow our rules if you're treating patients here, they would say no. You know, they're interested in it. They're trying to figure out ways to streamline that administrative burden. And I think we can continue to give states the ability to authorize who delivers care, but we need to force them to make that authorization pathway easier and more practical if they really do want to address the shortages that are out there. I think the New Jersey, yeah, I won't go into New Jersey.
I know. It's
I have some thoughts on that, but I won't go into it. But we'll be
okay.
interested to see what happens.
We'll have to have a part two.
Yeah.
But before we close, we did have another question that's just going to take us slightly over to Medicaid and CHIP. Specifically, they were wondering about the Medicaid CHIP telehealth toolkit, which really is a way for, if you click on the link, you'll see it's about states trying to expand access, with CMS encouraging states to expand access to telehealth for this population. And just if you happen to come across that in your work with different states and health entities across the country, have you seen any of that toolkit come into place?
I haven't yet. I think it's isn't it relatively new or not? I don't know.
Yeah, I'm
I was
not
just
as
looking at
familiar
it.
with it, but I think it's a
Yeah, it
nice.
just came
Yeah,
out. I'm hoping that they do, because
2024.
I'll tell
Yeah.
you that at certain times in trying to, for example, that Medicaid issue I was mentioning with telehealth, and okay, thank you, Nathan.
Yeah, 2024. Yeah.
Yeah, I'm hoping that they do. I think it's a really effective thing to use with departments. You know, when I've talked on certain occasions around the enrollment issue, they go, oh, well, this is a CMS requirement. So now we actually have something where CMS is saying it is not a CMS requirement that you have to be physically in the geographic proximity of the patient to be enrolled in the state's Medicaid program. So I'm hoping that states draw on that best practices, but I haven't seen it yet.
Um, I can tell that we all want to keep chatting with you. There is a question
Getting
about reaching out to you. If that, you can let us know if that is something you'd
sure.
like participants to do. Quinn has kindly agreed to let us record today's session, and we'll have the slide deck as well. But mostly we just are so grateful for your time, your knowledge, your insights, and I really appreciate you coming to join us today. So
Thank you so
thank
much
you
for
so
having
much.
me, and I hope it was helpful.
Oh,
All right.
extremely helpful. Take care,
All
Quinn.
right.
Thank you everyone for
Bye.
joining us. Bye. Oh, Melanie, do you have anything to add?
No, you took care of everything. Thank you again for joining us, everybody. And like I said, it has been recorded. I put the link in the chat, but I will also be sending out an email to everybody as a thank you with that information. Lots of great questions, and we will get back with any questions that we didn't answer. I can work on that in the email as well. Thank you, everybody, and have a great rest of your afternoon.
Take care. Bye.